Welcome to Direct Supply's Continuing Education Webinar Series. Direct Supply offers monthly webinars on a variety of topics throughout the year. The topic for today is Common Do-Nots of Seating and Positioning. My name is Robin Malik, and I will be facilitating today's meeting. Please note, the information contained in this presentation is intended to provide general information, but not advice about certain regulations and initiatives. This is not intended as legal or other advice, and each situation may vary depending on the particular facts and circumstances. You should not act upon this information without first consulting with qualified legal counsel. Today we are joined by Elizabeth Cole. Elizabeth is the Director of Clinical Applications at ROHO, a division of PerMobile Inc. Since 1985, Elizabeth has had many roles in the prescription and provision of seating and wheeled mobility. She has practiced as a physical therapist, managed a wheelchair clinic, provided reimbursement consulting, and developed and presented training and education programs. She now leads the online education initiatives and serves as a clinical resource for the product development, marketing, research, and compliance teams. Elizabeth has lectured extensively at conferences, trade shows, and universities, and has been published in industry journals. She is a member of several key industry organizations and is involved in many industry-wide work groups dedicated to regulatory and legislative policies related to complex rehab technology. And now, please welcome Elizabeth.
Thank you, Robin, and thank you all for joining this webinar and Common Do-Nots of Seating and Positioning. And this is a topic that I could speak a long time on, and we only have an hour, so I'm going to jump right in here. And I want to talk about some of the pitfalls that we sometimes fall into as we prescribe and provide seating and mobility and for our clients. And this includes sometimes using outdated methods or theories of seating, and maybe these are things that we learned way back when we started in seating and positioning, or sometimes even in school. And we still, we'll get into the habit and we still kind of practice with these. And there might be other alternatives out there and newer theories that might provide a better practice. And so we're going to look at some of those potentially outdated theories. And kind of along the same line is when we get into the habit of using a certain product or a certain, support device or type of product. And maybe we started using that initially because there wasn't anything else. And, now there's other alternatives out there. So, but some of these things sometimes get overused or inappropriately used. Another thing that I'm going to touch very briefly on is just the habit of providing products based on diagnosis and why that's a big no-no. And then providing packages of equipment. I'm not going to really talk about this so much, but I think sometimes we get into the habit of, for this type of client, we always use this, and this. And, maybe some of those things aren't necessarily needed by that particular person. So I'm going to touch on primarily the first two bullet points in this presentation. So I decided to do this a little differently than I've done it in the past, and that was to pick one posture and say, okay, what are some of the pitfalls that we fall into or things that we shouldn't do with this particular posture? And the reason why I picked posterior pelvic tilt and spinal kyphosis is because I think no matter who we are, no matter what your clientele is or who you deal with, this is probably the most common posture that we find among our our clients, and the one that we deal with the most, and the one that's sometimes the most frustrating. So I want to throw out the question is, so if you have someone who comes in and they're sitting in a posterior pelvic tilt, what's the first solution we should try? And, maybe you might say, well, we'll try this postural support, or we'll try this different orientation in space, or we'll try, a recline in the back, or, any number of postural solutions. And that's, if we do that, that's the first big don't, because we should never start choosing solutions until we know the cause. So the first thing we want to do with any client is look at the posture that they're sitting on, and then identify why. Why are they sitting like that? What is the cause? And that requires an evaluation. That requires looking at, all their range of motion, see if there's contractures or decreases in range of motion. Do they have muscle weakness? Where is it? Postural instability, or tone issues. And we're also going to talk a little bit later on, maybe it's something to do with the equipment. Maybe it's not even, primarily something to do with the person. So again, the big don't is don't just start pulling, solutions out of your bag of tricks, but really do that evaluation and identify the cause. So why would somebody sit in a posterior pelvic tilt? And that's a whole other webinar, the causes of postural problems. But we're going to just list some here and look at how we might address these. So it might be a matter of just poor core muscle strength, muscular instability, overall decreased muscle strength, poor posture and balance, or poor balance and stability, compromised endurance. These first three bullet points often you'll find sort of lumped together as the cause. Sometimes it's muscle or joint contractures, particularly in the hips or the pelvis or the spine. Again, we're going to talk a little bit later about it might be due to the equipment itself, where it's either the wrong fit or it's wrong configuration or not adjusted correctly. And obviously, a lot of times it's from discomfort and pain, and that may be from any of the above. So all of these are reasons why somebody might sit in a posterior pelvic tilt. So let's look at these first three and say, okay, what are some of the things we might try for a posterior pelvic tilt? And this is, when we look at why somebody sits like this, if they have weaker absent core muscle strength or poor endurance, it's hard to sit upright. It's hard against gravity when you don't have the strength. And, I can guarantee that a lot of you who have, quote unquote, normal strength and normal balance and stability are probably sitting more like the person on the right than on the left, because it takes effort to sit like this. We have gravity pushing down on us, and we have to balance ourselves against gravity. And so we tend to slide forward in order to gain stability and also not to have to use as much strength. So when we look at our clients, and I know one thing I learned way back when was the rule of 90-90-90, and I'm sure a lot of you heard this as well, depending on how long you've been in the industry and doing this, and that's that the ideal posture is 90 degrees at the hip, 90 degrees at the knees, and 90 degrees at the ankle. And when you look, unfortunately, at our wheelchairs, they are set at a 90-degree seat-to-back angle. And so in order to sit correctly in those, we have to sit at a 90-degree hip angle. And so how many times is this really realistic? Is this, can we expect our clients, particularly if they have poor muscle strength, poor endurance, poor stability, can we expect them to sit upright when we put them in this 90-degree seat-to-back angle? Is 90 degrees at the knee even attainable with most adults? Probably not. That's why our footrest hangers aren't at 90 degrees, because they probably hit the casters, or the feet would. Probably the only joint that's realistic is the ankle. So, when we look at what we sit in, I would challenge any of you to think of something that you sit in on a daily basis for any length of time that's a 90-degree seat-to-back angle. If you look at your office chair, or you look at the seat in your car, if you look at, even seats now in when you go to a seminar or a restaurant, probably the only chairs that you might sit in that are 90 degrees, big dining room chairs, dining room table chairs. And they're not comfortable. We don't stay in them for any length of time. So what are some of the alternatives to this? Well, unfortunately, sometimes an alternative that's used a lot is a wedge cushion. And a wedge cushion is great when it's used properly. So if someone is sliding forward because they can't keep themselves upright and you put a wedge in there, then it can help keep that pelvis to the back of the chair, and it can help keep that person from sliding forward. And it can, once you get the pelvis kind of bucketed in there, then the trunk tends to follow, and we keep an upright trunk. So this is great if the person has more than 90 degrees of hip flexion. So, and we'll talk about that in a second, but first of all, they have to have 90 degrees of hip flexion. And if you look at the middle picture, I don't think I have a pointer here, I apologize. But if you look at the middle picture, this person can flex the hip greater than 90 degrees so they can sit at that angle required by a wedge cushion. However, even at that, anytime we lift our knees up, the pelvis is going to have a tendency to rotate back. And so what we need here is we need to have a good support behind their back, and that's the picture on the right. So either really, really good tight back upholstery or even, a solid back of some sort to help, again, as we lift the knees up to go into that wedge to prevent that pelvis from rotating backward, because that's exactly what we're trying to prevent, is that backward rotation of the pelvis. Now, what happens when the hip does not flex beyond 90 degrees? And this is probably a lot of our older clients, clients who have been injured for long term, and they just don't have that degree of hip flexion. Well, what happens here is, as we raise the knee up, again, the pelvis is going to have a tendency to rotate back and to rotate posteriorly. And so if we don't have hip flexion and we raise that knee up, then the only thing that can move is the pelvis. And if you look at the middle picture, that pelvis is going to rotate into a posterior pelvic tilt. So the tendency to slide is actually increased if the person does not have more than 90 degrees of hip flexion. It's even worse if they start off in a contracted state, either because of a hip extension contracture or a fixed posterior pelvic tilt. So that figure to the right, if we have somebody who's fixed in this kyphotic sort of slumped posture, and we try to raise the knee up, we don't even have 90 degrees. So in these cases, what we end up doing is trying to put the proverbial round shape into the triangular hole. And so what you end up seeing is, because that pelvis rotates back and the hip doesn't have enough flexibility, then the person's kind of just perched in that on that chair. And so we haven't addressed the posterior pelvic tilt. They continue to slide forward. They're not using the full seat depth, and so we've really set them up for even worse posture and possibly some skin breakdown, because they don't have good redistribution of pressure, and they're not loading the femurs like they should be, and probably a lot of discomfort. So again, wedge cushions are great, but be really, really careful that the person has the correct amount of hip flexibility to be able to sit in that, and so that the equipment matches their shape. Sometimes I think we try to match the body shape to the equipment, and we can't do that. We have to match the angles and the shapes of the equipment to the person's need. So let's look at some other potential solutions. Well, again, we started out with a flat seat and back, and it was at a 90-degree seat to back angle, but we're not flat, so we're not Gumbies. When we look at the picture over to the left, our ischial tuberosities sit down about 1.5 to 2 inches lower than the femur. So we're not flat across that the inferior surface of our pelvis. And again, you can see in the next picture over how the greater trochanters are higher than the ischial tuberosities. And of course, the same for our spine and ribs. We have contour to the ribs, and we have our normal lumbar lordosis, thoracic kyphosis, and cervical lordosis, although that doesn't often come into play in our seats and backs. But we definitely have the posterior curves in the sagittal plane as well. So let's look at using contour. instead of, changing an angle and providing an angle that doesn't fit the client, maybe use contoured seating where we have a posterior well of some sort in the back that will accommodate that height difference between the ischial tuberosities and the femur. And that can sometimes help keep that pelvis into the back of the seat and help discourage that sliding forward. So we're not only matching the shape of the client for better pressure redistribution and for comfort, but also to help keep that pelvis in the correct position. And then the same for the back. If we add either minimal contour like the back on the left, or more lateral contour like the one on the right, we're matching the one on the left, the back on the left here is just matching that natural contour of the ribs, because again, we're not flat on the back, and so sometimes adding that contour can help a good deal with helping to maintain and posture. Another thing that we can look at, again, in considering the fact that most of us in what we sit in on a day-to-day basis is not a 90-degree seat-to-back angle, can we add a little bit of open seat-to-back angle? So in the middle picture, you're seeing someone who has the potential for upright posture, but they slide forward in that 90-degree seat-to-back angle. And so we've added a little bit of a fixed recline or a little bit of an open seat-to-back angle, and that can really help to reduce the impact of gravity. So we've brought some of our body weight sort of behind that line of gravity and can help balance that person so they don't have to use quite as much muscular effort to hold themselves upright, and as much they won't fatigue as quickly and tend to slide as much. For someone who is in that fixed posterior pelvic tilt and kyphotic position, again, and looking probably at a lot of our older clients or people who have been injured for many years and they've just kind of fallen into bad posture, we're not going to correct their posture, but this matches much more closely to their shape. And so again, it allows them to use the full seat depth. It allows them to have more contact with the seating, so the pressure distribution is much better and definitely better comfort. And for some, even increase their visual field as well. If they're sitting in that slumped posture in kyphosis, they're probably looking at the ground. So, we do have wheelchairs that have back canes that are adjustable in angle, and those are great for providing that postural assist. Now, maybe you say, well, I only work with, standard wheelchairs, and so how do I do that? Well, sometimes you can do it, even if your back posts and your seat rails are welded at 90 degrees. Sometimes you could put a solid back of some sort on there and use the hardware to actually create that angle in the back. So you might be able to do that. And another thing that we use quite a bit as a postural assist is just a little bit of tilt in the frame. So again, if we're sitting at 90 degrees, seat to back angle, and like in the left-hand picture, and we're sitting upright, then gravity is just coming straight down, and it's very difficult to maintain posture against that. So we slide into that posterior pelvic tilt in the middle. If we put a little bit of fixed tilt in the frame, then sometimes that's enough so that we're balanced better against gravity, and so it takes a lot less effort. And again, I think if you really look at most of what we sit in as able-bodied people, that you'll find that the seats either have a little bit of tilt in them, or they have a little bit of open seat to back angle, or sometimes even both. So, and why do we expect our clients to sit in something other than that? So again, this does require a wheelchair that's a little bit more higher end than your standard chairs. But if this is what the person needs for postural assist, then we can try to provide that for them. Another thing that we sometimes use to keep our patients from sliding forward is an anterior pelvic support. And this definitely is a great solution when it's used as a secondary support. And what I mean by that is the anterior pelvic support should never be used as the sole thing to try to keep someone from sliding forward in their chair and sliding into that posterior pelvic tilt. It's sort of an adjunct. It's something that you use when you've used things like contour or an open seat to back angle or even a wedge cushion if it's appropriate, or some of the other postural solutions. So, and this is sort of that just last little bit that you want to put on there to really help secure that person. An anterior pelvic support really cannot secure the pelvis on its own. If there's other things going on that haven't been addressed. And if it's used incorrectly, it really can be ineffective and sometimes even harmful. So this is just, this gal on the left, she actually came into the clinic that way. That's not, it's not like she came in and had to wait and sort of slid forward to take a nap. Sad to say. I'm sure a lot of you have, unfortunately seen pictures similar to this. And the reason why this looks so bad is that the anterior pelvic support is grabbing onto soft tissue. And I did this blow up on the right because I think on the left you can't even really tell that she's got an anterior pelvic support on. You can see her shoulder harness. And she's slid down so far that she's actually slid under the belt, and so the anterior pelvic support is kind of resting on top of the lower part of the chest support. So hopefully you can see that in the blow up. I know it's not that clear. But so she does have an anterior pelvic support on, but the problem is it's just grabbing onto soft tissue. And this can be uncomfortable. I know sometimes these things get cranked down really tight. Think of what that would feel like. I know what it feels like when my belt's too tight or my pants are too tight after I've had a big meal. And it really doesn't prevent sliding. She's slid right under that. And, unfortunately, there are reports of people who have slid under so far that they've actually, we call it submarined, slid down and actually been strangled by the anterior pelvic support. So what can we do to prevent that? Well, we can try to grab onto a bony prominence. The reason why that seatbelt didn't work on the previous one is because, again, it was grabbing onto soft tissue. So we want to either grab onto the ASIS or go in front of the greater trochanter. And the first, the slide on the left, that's the anterior grabbing onto the ASIS, would probably come up at more of a 45-degree angle, and that's kind of classically what I learned way back when was, you try to position the anterior pelvic support at a 45-degree angle to grab onto the ASIS. Well, and that's good, but unfortunately, you actually still can slide forward. If you look at where the greater trochanter is in front of that, unless you've really grabbed onto this ASIS, there's still a possibility of sliding forward. And sometimes you really can grab onto the ASIS if someone's bony and, it doesn't have space there. But sometimes, especially with children where there's not enough space, or sometimes even people who have, a lot of tissue around their pelvic area. So a better option might be to do either a 60-degree angle or a 90-degree angle, and that's those two middle pictures, where you're actually putting you're securing in front of the greater trochanter. And that can really be effective in helping to prevent someone from sliding forward. Or if you have that person you really need to anchor in, then you use the 45, we'll call it 4-point seatbelt with both. But just the main thing is you've got to grab onto that bony prominence. So I think I have an after picture of that gal later, so we'll see what we did to help with that. Another thing that you might use is a lumbar support, and again, this is sort of like the wedge cushion and the anterior pelvic support, they are great when used correctly. A lumbar support can help to, I think, particularly with comfort, but it can help to encourage sort of that upright spine and prevent that lumbar kyphosis. However, there are a couple of things you have to be careful about, and that's the size of the lumbar support, where you've placed it, and the person's flexibility in their spine. So if it's too large, too thick, positioned too high or too low, or if the person just has no flexibility in their spine, in that lumbar spine, the only thing you're going to do if you put that lumbar support in is push the person forward in the seat. And really, that's not going to do anything to encourage good posture. As a matter of fact, it can actually cause the person to slide forward even more, and it's certainly not comfortable. So you cannot, I don't care, what lumbar support you use, you cannot create a curve in a spine if there's not the flexibility there. And I see, unfortunately, a lot of lumbar supports used with some of our older clients, and they probably don't have even a flat spine. I mean, sometimes they're already fixed in that kyphosis. So you're not going to create a curve where there is none. So again, that means, assessing spinal flexibility. If it's the right size, if it's small enough, if it's thin enough, it's positioned right at the lumbar spine, and the person has the flexibility, then yes, it can help to encourage that lumbar extension, certainly more comfortable. But remember, you're addressing the lumbar spine, so you still have to address the pelvis with some of these other solutions. Your lumbar support is to help with the spine, but it's not going to help control the pelvis. So it cannot be used as the sole thing that you're going to use to help prevent that posterior pelvic tilt, unless it's more of a behavioral discomfort type of thing. So again, make sure that the person first of all has sufficient flexibility. Then look at what you're using and make sure. I mean, honestly, you can use a pretty thin foam, not real thick. Most of us don't have, especially as we get older, unfortunately, a whole lot of lumbar curve. So make sure it's not this big bulky piece that's, just they're not even going to have anywhere near that flexibility in their spine. Make sure it's small enough that it just sits in the lumbar area and doesn't go up into the thoracic spine, and is positioned again at the lumbar spine. Another thing we really want to avoid is overstretched swing upholstery. This just does absolutely nothing for posture, and I would just challenge anyone, and I'm sure you all know this. I wish I could challenge every, hospital administrator or nursing home administrator or purchasing agent to try to sit in, hammock upholstery and maintain any kind of good posture, never mind comfort. So one of the things we sometimes use is to put a solid board across the upholstery, and that's okay. It certainly can provide. If you look at the woman in these pictures, she was sitting in a sling, obviously sitting in a pelvic obliquity, couldn't keep her pelvis level, and they put a solid board under there, but they also had to replace the cushion because if you look at the cushion in the middle picture, that had, even though it was a very firm foam, it had started to take on the shape of that hammock. And the other thing is, replace the upholstery. Overslung upholstery just says, again, absolutely nothing. We need good quality upholstery under that, especially if you're not going to provide some kind of a solid board under there. Anterior trunk supports, again, these are sort of like your anterior pelvic support, where they can be a really great secondary support. So they should never be used just on their own. to try to keep somebody from, sliding into that posterior pelvic tilt or curving over into increased kyphosis, because they, in and of themselves, well, if you look at the picture on the left, basically all of this secondary support is doing is allowing that little girl to just lean forward and hang there, hanging out on my anterior trunk support, and it's done nothing to encourage good posture. On the other hand, again, this gal that we've seen on the right, it also did nothing to help her, prevent her from sliding forward. So it definitely has to be used sort of as an adjunct to other solutions, seating solutions. So we need to look at other things first. Is the contour correct? Is their angles correct? In this case, the little girl on the left, she was in an anti-thrust seat that no longer fit her, so it wasn't keeping her pelvis in alignment. Because of that, and also her seat depth was incorrect, and so her feet, she had a lot of tone, and so her feet would kick out into extension, and she kept breaking the Velcro off her shoe holders, and so she has foot plates there. Her feet just aren't on them. And she was in a totally flat back, which wasn't doing anything to encourage her posture. So, so we need to make sure that the anterior pelvic support is that we've addressed other problems before we just put an anterior pelvic support on to try to keep somebody from leaning forward. And sometimes there are, I would say, many cases where once we address the other issues, we don't even need it. And these two gals were kind of classic cases of that. This little girl over here, they provided a contoured back. They put her in a seat that had a well size that was correct for her. The seat depth was correct. She no longer even needed the shoe holders because her feet stayed on the foot plates, and she no longer needed the anterior pelvic support. And the same with this gal, and she's a good example of this. Now her anterior pelvic support goes in front of her greater trochanter. So that's really helping to hold her from sliding forward, and it puts her in a much less dangerous position than she was in. Both of these young ladies had never been independently mobile, and because their seating was addressed, they could then access controls to drive a power chair and have independent mobility. Medial thigh support. This is another thing that I see misused a lot or overused a lot. And unfortunately, hopefully, everybody on this call knows better than to ever use it to prevent sliding. But honestly, I do see medial thigh supports out there, and that's, that's pretty much why they're on there, is to block the person from sliding. And this cushion, unfortunately, is a clear example of that. And the picture on the picture on the left, the picture on the right is a really good example of inappropriate size as well as positioning of a medial thigh support. So a medial thigh support really should be used for what reason? Well, it should be used to keep the person in the correct amount of hip abduction, so to prevent hip adduction. And that's it. I mean, that's basically what it should be used for. So in order to do that, we have to make sure that it's positioned correctly and that it's the right size. So it really should be, it absolutely should be placed at the distal end of the upper legs. So down, just proximal to the knees, at the very end of the seat, or sometimes even partially off the seat surface, so that it just addresses the thighs and is not up in the groin. It should never, ever, ever be up into the groin area. If someone is sliding and they're sliding into that medial thigh support and so that it is in the groin area, then we need to look at, okay, what else can we do to help prevent that person from sliding. If you look at the picture on the right, this is way too tall. I mean, at some point, he may actually be able to roll underneath that, if not into adduction, at least into internal rotation. So it should really only come up parallel to the surface of the thighs. It should be just long enough so that it helps to keep the legs in proper alignment, but it's not so short that we get just a big peak pressure at the area that area of the thigh, particularly if someone has a lot of tone and they're adducting with some force. So we want to make sure that it's long enough that it has some good pressure distribution across the thighs, but not so long again that it goes into the groin area. And then just wide enough to achieve the degree of abduction that you're looking for. I see a lot of them used with kids, and they're like huge. And sometimes we do want to achieve a little bit of, a little bit of abduction with our kids versus just neutral or midline. But some of these are way too wide. So make sure it's the right size and the right placement. Elevating leg rests. I see these just so overused, and sometimes for the wrong reason. And I see them, unfortunately, I still see them used to help prevent people from sliding. So, Mrs. Jones is sliding out of her chair, so we'll put a wedge cushion on, and then we'll put elevating leg rests on, and, that she can push against. And unfortunately, we also see them a lot on standard chairs, just because, or they're put on there to, get rid of lower extremity edema, which we know can't happen unless your foot is above the level of your heart. So the main thing is that I see these used a lot with people who don't have enough hamstring length. When we think about it, in the first picture on the left in A, the hamstrings are nice and they're on a slack because this person's got their feet tucked underneath them. As you bring the leg out, the hamstrings get stretched a little bit, like in B, and then as we pull them way out to get onto an elevating leg rest, they really get stretched. And for some people, they get stretched beyond their limits. And at that point, as we pull and the hamstrings stretch beyond their limits, it's going to have to start pulling on the proximal end, which is the ischial tuberosity, where it attaches to the pelvis, and that's going to cause the pelvis to rotate posteriorly. So if we're using elevating leg rest to causing them to slide more, because we're forcing that pelvis to rotate because they don't have hamstring length. And again, unfortunately, I see these used with a lot of older clients. In order to sit with an elevating leg rest straight out, you have to be able to sit with your legs right out in front of you. And I know I'm not elderly, and that's actually a little hard for me now. So as we get older, we lose stretch in our hamstrings. So I would say a lot of our older clients just don't have the flexibility. So what should we do? Well, let's look at tighter knee angles. If we put the knee, if we can use a 70-degree hanger versus a 60-degree hanger or an 80-degree hanger, that's going to put a lot less pull on the hamstrings. Now, if someone asks, or we could combine that tighter knee angle with an open seat to back angle, because again, that's going to put less stretch on the hamstrings as well by opening up that hip. Sometimes you can't get around it. You absolutely need the ELRs to help prevent lower extremity edema. It's not going to get rid of it, but it might help to prevent it. In that case, if you raise the elevating leg rests up, then as soon as they go back down again, you need to readjust the pelvis, and that just needs to be part of their care routine. Another thing we really want to look at is wheelchair setup. And In some respects, I probably should have put these slides first because these are sometimes really simple solutions, and they're the things that we really should address first before we start looking at, you know, the causes that have to do with the person. If there's something wrong with the seating or the wheelchair, we should address those issues first. So I know when I do an evaluation, before I do anything, I mean, I look at the person and how they are sitting in their current equipment. And what do I see that could possibly be causing them to sit in their bad posture? And so we're going to look at things like seat to floor height and leg rest height and armrest height and things like that. So let's look at armrest height. You know, a lot of times if someone can't, if they really do need to use their armrest for support and to help with their posture, then if it's too high or too low, they're going to probably slide into abnormal postures. Maybe if it's too low, they're going to lean over to one side to access that one armrest, and now they're in a pelvic obliquity, or they're going to slide forward in the seat to lower themselves in the seat so they can reach those armrests. So when we look at armrest height, it should be such that the shoulder is neither elevated or depressed. So it's at a right height that our shoulder, and if you look at the picture on the top, the shoulder is in a nice neutral position. And also the forearm is supported, you know, parallel. They can put their forearm on the armrest, and it's parallel to the arm pad at that with a 90-degree angle at the elbow. So make sure that that armrest height is correct, because if it's not, that can be causing some of your postural issues. Make sure that the foot plate height is correct. Your foot plates should be, as we see in the middle picture, the foot plate should be at a height so that your femur is parallel to the seat surface. We don't want our knees way up in the air, and we don't want them below, you know, the femur sloping down so that the knees are lower than the seat surface. The femur should be parallel to the seat surface, and the feet need to be well supported. And I think a lot of times we don't address foot support like we should, and we don't look at footrest height. And again, that can cause some significant postural issues. Seat to floor height. If you have a foot propeller, that seat to floor height needs to be low enough so that the person can put their heel out in front of them on the ground, and then they need to be able to drag their foot underneath the seat in order to get good propulsion. So, you know, it's kind of like if someone's propelling with their upper extremities, the wheel has to be at the right height and the right position for them to get a good stroke with their arm. Well, we need to get a good stroke with the leg as well. So we need that seat to floor height to be the proper height in order to expect someone to propel with their foot and maintain their posture. If it's too high, they're absolutely going to have to slide forward in the seat in order to reach the ground. And then we need to look at fit. So, you know, again, look at the armrest height, look at the footrest length and the leg position, look at the seat to floor height, and then look at the size of the wheelchair. If my wheelchair is too wide, I have all kinds of room to slide into poor postures. I can slide to the side, into a pelvic obliquity. My pelvis is not supported, so, you know, I can slide forward. And also, the wider, if my chair is way too wide for me, I'm not going to be able to propel that very easily. And unfortunately, some of the folks that I see in the wheelchairs that really don't fit them are people who are already having trouble propelling because of, you know, decreased upper extremity strength or endurance or things like that. So we don't want it to be too wide. On the other hand, obviously, you don't want it too narrow. We don't want things rubbing up against the hips or the thighs and causing someone to rotate out of discomfort. So how do we get, I'm just going to really briefly mention measuring because I think this is so important, and I think it's something that's overlooked. And I could spend an hour talking about how to measure somebody properly for wheelchair and seating, but very quickly for seat width, I'm going to measure the widest part of the seated anatomy, and that's usually the hips, but sometimes it might be the thighs if they're, particularly large. And so I'm going to take that measurement and the hip, hopefully it's the hip measurement, and 9 times out of 10, that's the size chair I'm going to order. And I know that I learned you add 2 inches, an inch for each side. And it wasn't too many years after, starting this that I started scratching my head thinking, what are those 2 inches for? All it does is make the chair too wide in many cases. So there are times when you are going to add an inch or at the most 2, and that's if you need to have room for other things, like if someone's wearing, a KAFO, or if they have a very high prosthetic, or if there's hardware and maybe some lateral hip guides or lateral thigh supports. So I need some extra space for those. But again, things that I try to keep the chair as narrow as possible. If there's a potential for growth, particularly with children, or if I know there's going to be, if I can sort of predict a weight gain, or for certain body types where, maybe there's a lot of soft tissue, I might add an inch maybe for kids too, but I try to fill in that space initially so that the chair fits them at the time. Want to keep it as narrow as possible. So it's narrow enough to support the pelvis and keep it in good alignment, allow adequate wheel access if that's the case. I see, unfortunately, a lot of children in chairs that are just way too wide, and they're struggling with their little arms to, reach the wheels. So, but then again, we don't want it so narrow that it rubs. Seat depth, this is another one that I see a lot of don'ts out in the field with just really inappropriate seat depth. And probably with adults, I see seating that's too short more than too long. But if you look at, and this is unfortunately an extreme case up in the top picture, but this was a real case. This is the way the woman came into clinic. And when you have a seat depth that's way too short like that, you are absolutely setting someone up for pressure injury because you're not loading the femurs. They're not doing their job as to taking, some of the body weight. And you've got all kinds of possibilities of legs falling into a windswept position or abduction or, poor lower extremity positioning and discomfort. It's just not comfortable. On the other hand, we don't want the seat depth too long because then it presses into the back of the knees, and that's going to cause someone to slide forward. So for seat depth, I'm going to put the key thing on this is position the person in their most upright posture, the posture that you're going to try to achieve through your seating, and then measure from the back of the pelvis to the back of the knee, and then subtract something. And there's no rule of thumb. Again, I learned you subtract 2 fingers, you subtract 3 fingers, you subtract 2 inches. There seems to be no consistent rule, and that's because there isn't. You should definitely subtract at least an inch if somebody needs full support under their femurs for good pressure distribution and good lower extremity alignment. For some people, you might want to subtract more than an inch. 2 inches, maybe, sometimes 3. But and that's for someone who maybe is tucking their feet underneath their chair more for with a really tight knee angle, or someone who is foot propelling, someone who's just they need support under their femurs, but they have some reason why they need to sort of tuck their feet back further. And then back height, again, I see a lot of back heights that are too high, and I think sometimes we think, oh, well, the person needs support, but a lot of times these are folks who have good trunk control, they have good stability, and by giving them a back height that's too high, basically we're restricting their upper extremity movement, not only for propulsion, but for just reaching behind them or out to the side. So, we don't need the back way up to the shoulders, or sometimes we don't even need it, over the scapula. So if someone has, we really can restrict their upper extremity function. On the other hand, we don't want it too low because then we're not giving the support they need, and now they're absolutely going to slide into poor postures. And the picture I have here, actually this back is not an appropriate low for this woman because she's playing tennis, but I didn't have a real good picture of someone with in normal everyday use with a back rest that's too low. And that's a good kind of segue into, okay, how do I determine what the right height is? And this is a very individual thing. It's very, I don't think that there's any good measurement to take. I basically use my hands and as support and find that sort of sweet spot for each person where it's high enough to give good support, but not so high that it restricts movement and function. So what have we done so far? We've looked at how we can encourage optimal posture through shapes, angles, orientation, secondary support, wheelchair adjustments, and correct fit. But I want to add a little something here in these last couple of minutes, and that's to say don't stop there, because we also need to look at protecting the skin. This is huge for most of our clients. I can't think of anyone who's sitting in a wheelchair for any length of time where skin protection is not, a factor, and where we don't want to ignore that. So let's really quickly look at the materials. How do we decide what material to use? Because we have foam, we have gel, we have viscous fluid, we have elastomer material, and basically all of these can be divided into solids and fluids. We have two basic different types of material in our cushions that are out there. Solids, as you see on the left, when I sit into them, and you can consider that, ball to be your ischial tuberosity, I guess. And when I sit into it, I compress it. And at some point, I'm going to reach the lowest point, and I'm going to have compressive forces pushing back. Also, when I move on the cushion, a solid does not move with me. And so I'm setting up shear forces there across that, the bony prominence. Fluids, on the other hand, when I sit into a fluid, it's going to envelop my whole shape, and it's kind of like sitting into water. We don't feel, we don't feel peak pressure points anywhere like you do on the left. The force is equally distributed, and as I move, I don't feel shear forces in a fluid. So let's look at in our solids, and that includes foam or elastomers or gel. These are perfect solutions for the right person. I'm not, I hope throughout this presentation you know that I'm not saying don't use any of these. Just make sure that you're using things correctly. And so for some people, if they're, active or moving around or in and out of their chair, or they're not at sort of higher risk for, I don't like to use that word, but for pressure injury, then these might be appropriate. But again, consider that we are going to have at peak pressures and compressive forces at the point of deepest compression. On the other hand, with fluids like our viscous fluid or air cushions, as we sit into them, we have those hydrostatic forces that are equally distributed and little to no shear. And I also want to dive a little bit more into this concept of immersion and envelopment. And when you sit into a fluid, and not only do you immerse into it, like in the left-hand picture, but it conforms to your shape. It conforms to your individual shape of your individual body, and that's what we call envelopment. And there we now have scientific research to show how that really does help to prevent pressure injury, because it reduces stresses and strains in the muscles and the fat and the skin tissue, that whole envelopment process. So when you're looking at, excuse me, your folks who really need skin protection, consider your fluid materials. If you're looking at a combination where you maybe want some more stability and seating as well as and contouring as well as immersion and development, that's when you can look at your combination cushions with foam and air, or you can look at air cushions that have different compartments, so either 4 separate compartments or even different height cells, excuse me, to give a little bit more of that positioning. So again, just to conclude, good steps in seating, make sure that the first thing you do is observe the individual in their current equipment. Don't just jump into, trying different solutions. Perform your seating eval, identify the cause of your poor posture, and then you want to address solutions or use solutions or try solutions that, that are going to address those particular causes. Definitely look at the wheelchair fit and configuration and make sure it's appropriate for that person, and then choose the best materials for your skin protection and positioning. Okay, I didn't leave a whole lot of time. I'm sorry for questions, but Robin, maybe if there's some that I could answer.
No worries. Yeah, we do have a couple questions that came in already. Okay. The first one is the anterior pelvic support considered a restraint?
Well, that depends on on where you work. Where this really would come into play would be in nursing homes, because there is a mandate that says you cannot, restrain the nursing home resident. Now, some nursing homes will say that as long as the anterior pelvic support is used specifically for posture, then it's okay. Some will say as long as the physician signs off on it, it's okay. Some will say as long as the family signs off on it. So unfortunately, each nursing home seems to interpret that law in their own way. And so if you're working in a long-term care facility, then it would depend on how your particular facility interprets it. Some of them will say, absolutely not, you cannot use it unless the resident can take it on and off themselves. I think that's unfortunate, because I think there are many cases when it's a lot safer to have that anterior pelvic support.
All right, thank you. The next question is, would you recommend the knees be positioned below the hips for THR patients when seated? As far as I know, the rule is that you don't flex the hips beyond 90 degrees for THR, and so I would think that 90 degrees would be perfectly appropriate. And I know also it depends on the age of the client, and there are some surgeons now who are not as adamant about that. Honestly, sitting at 90 degrees from my understanding, is not going to stress that instrument. So I don't see the necessity of that, but I would definitely, talk to the specific surgeon if you have a question about that. Okay, great. The next question is, I'm curious about lateral supports. I'm working with a lot of people who cognitively have a difficult time readjusting their posture. The lateral support helps, but they still lean. What other options are there?
Well, and I hate to give this because it's a non-answer, but I think there's many reasons why they lean, and so I think it's going to be different for a lot of different people as to why, why they are leaning. Is it a question of tone, and can something be done to, sort of reduce that tone? Is it the pelvis? Have we, putting lateral supports on is great, but if my pelvis is still migrating into an obliquity, do I need to address an obliquity? So looking at, what they're sitting on and how they're sitting, do I need to use some kind of pelvic obliquity buildup? Is it because, armrests aren't appropriate height? It's hard to answer because there's just so many reasons why people might lean to the side.
Sure. All right. We have time for one more question. So this one is, with increased kyphosis, how low is too low with back support? With back support.
I assume you're talking about a fixed kyphosis. And one of the things that I guess at that point, if they need postural support, if they don't have good stability, I would at least go to the apex of the kyphosis, and maybe even a little bit above that. But if they're fixed, I definitely wouldn't go above or too much above the apex of the kyphosis or the apex of that curve, because anything above that is sort of wasted back. I think you could go lower than that if, in fact, they had appropriate stability, appropriate, postural stability. But I'm kind of guessing that they have some postural issues if they're in that fixed posture. So, again, it's so dependent on the person and what the other variables are.
And now, for anyone interested in learning about the seating and positioning products Direct Supply offers, I would like to introduce Kelly Sullivan, our Senior Product Consultant. Kelly keeps up to date on current senior living trends and provides general product consultations, program overviews, product sales training, and customer demos. If you've been to Direct Supply before, you'll remember Kelly as your product and formulary selections expert. Please welcome Kelly.
Well, thank you everyone for hanging on the line here for just an extra couple minutes. Today we're going to talk through some positioning solutions as it pertains to the wheelchair solution package. So if you look at solutions in a holistic way, as you look at a wheelchair, there's lots of different options out there that can help you get to a positioning solution for your client. So here we have, as I mentioned, kind of a holistic approach to those positioning solutions. You'll see the head support, which provides positioning to the head and neck while also improving a patient's line of sight. A positioning back can allow for precise contours for any spinal curvature and is adjustable in height, depth, and recline. It also can be customized in some cases. Arm supports provide support for contractures, upper extremity contractures, and tone, while also helping to decrease the risk of finger drop. Foot supports maintain proper foot positioning while also reducing pressure points on the heel and foot. They also provide protection for the foot from door frames and other obstructions. When we talk about pressure redistribution, there are all kinds of different options, and there are a million cushions, as you know, out there. But we want to talk, I think, specifically about cushions that really help alleviate the pressure points from the coccyx and IT area, and really helping to drive better outcomes for those who are in need of assistance with those stage 3 and 4 wounds. A complete pressure distribution, seating, and positioning system can also provide patients with skin protection, improved comfort, reduction in the effects of shear, and redistributing pressure from the IT area as well. And then lateral trunk supports up there in the left-hand corner. Elizabeth talked quite a bit about this today as they improve postural alignment, which may aid in improved breathing and digestion as well. So let's go ahead and take a deeper look at those lateral supports that can help with lateral leaning. The first one I point out here is the Panacea lateral support system, which adjusts laterally and vertically with Velcro to accommodate the individual's needs. The wrap attaches to any standard wheelchair or recliner, so it's very versatile. It can be used with multiple different types of products. A side minder helps to prevent lateral leaning while keeping residents upright in a chair. The adjustable rigid center bar is a durable answer to aggressive leaners. If we look at the side hugger, this lateral support is appropriate for mild to moderate leaners. It hugs the resident's trunk, and the back cushioning simply fits over an existing wheelchair back. If we look at the cushion that I have on this particular slide, we're really focused on the ROHO Quattro Select with the Smart Check option. This is a great product. This cushion is also customizable, but with the use of an air pump. There are 4 quadrants that can be manipulated depending on the positioning need. The same rule apply in that you can add air to the side that they are leaning and remove air from the opposite side. So you're really helping to support them and center them into that seating surface. ROHO now has an air maintenance tool called the Smart Check that you see there. It looks like a little handheld gauge. And it's a sensing device used to set up and monitor the resident's inflation range. And why this is important is, it can be a little invasive if you're using your hand to check the air level. So this is a great way to minimize the invasiveness of checking the air levels for that end user. All right, moving on. We're looking at posterior pelvic tilt. Again, another heavy topic we talked about today that definitely affects long-term care. The wedge cushion, also mentioned in the presentation, has a gradual slope with a height at the front of the cushion and with a goal of positioning the pelvic region back into the seat. A wedge might be a good start if the posterior pelvic tilt is minimal. If it's a more advanced issue, then we might be looking at the anti-thrust cushion down below that. The contouring on this cushion, which I call a minimum shelf, is to establish a gentle reminder for the resident to reposition themselves back into the pelvic region of the seat if they tend to slide forward. This would be a more aggressive solution, as I mentioned, than the wedge. And then I also have a tilt and space chair pictured here. A tilt chair is really a great positioning option to consider, especially for residents that tend to lean or slide forward. The axis of the seat itself will tilt back to help redistribute the weight, driving down on the IT and coccyx region. Weight will even out and with each degree of tilt. So the more tilt, the more weight distribution that your end user is going to experience. All right, kyphosis. There are lots of different types of kyphosis situations, but one of the things that's nice about the products pictured here is that they are customizable and that the air is designed to really be light and allow for to accommodate that person, your client's body. Agility backs integrate ROHO's air flotation technology, which is fully adjustable to tailor air volume to comfort level. These backs are also designed to adapt to virtually every wheelchair, so and it doesn't matter what model you have, it's going to work. And once properly installed, they'll stay secure and in position. There are 3 options to choose from, as pictured on this slide here, from medium, mid, to max contour back systems. The recommended patient for the first one you see there, the medium contour back, would be a patient that requires basic posture support, is an independent wheelchair user, and has good trunk support. So it's pretty agile. The mid-contour back system is appropriate for a user that requires postural support, is somewhat dependent with transfers, and needs minimal trunk support. And lastly, the max contour back system recommends that the patient requires a significant amount of postural support, is more dependent with transfers, and needs the maximum amount of trunk support. As you can see too, just at the picture, that as you progressively move through the screen from the medium to mid to max, the lateral widths will increase too to provide additional lateral support. The key takeaway for this back system really is that they are strong, durable, adjustable, and comfortable for your client. All right, let's talk about foot drop. One of the products we have pictured here is the foot positioner. This helps to protect the lower leg and foot from unwanted movement from a heel cutout with a heel cutout for pressure relief. Right next to it, the complete feet is available with or without the separator and can adjust for multiple support angles. So it really accommodates both feet versus just the one. When we look to the molded foot, this gently holds the foot in place with a sturdy, durable construction. And then the foot cradle at the on the far right there on the bottom accommodates existing flexion contracture. The cushion sides and back help prevent feet from slipping off the footrests. All right. When we talk about contracture management, we're really just talking about upper extremity contracture management as it pertains to arm and wrist. So there are some pieces here that, as pictured, that can help with managing that. One here is the Panacea arm. It's a rotating arm, 270 degrees, with crown palm area to avoid finger contractures and contoured cradle platform. The Comfort arm, which is down below there, is an articulating armrest with multiple positioning options with molded elevated left or right mount. The platform's 20-inch length provides wrist drop, and the open palm accommodates splints and allows for finger extension. The elevated option allows front of arm to articulate in 10-degree increments, and the arm depth adjusts 4 inches. So pretty flexible in terms of what your resident or your patient might need. All right, lastly, this is my last slide here. We talk a lot about pressure management and positioning. Stage wounds can be a reality in our world. We all know this, and involves multiple layers of treatment like proper hydration or turning, repositioning. But some surfaces are rated for advanced pressure management through stage 4 ulcers, such as select ROHO cushions. ROHO has evolved over the years and has several cushions that are solutions for both pressure management and positioning today. First one we're going to look at here is the ROHO Contour Select, which helps to position the pelvis back into the wheelchair and centers the resident comfortably in the middle of the cushion. There are 4 quadrants that can be customized to fit the needs of the user through a system called ISOFlow memory control, which locks the resident segment position into place. The cushion also aids in prevention and healing up to stage 4 pressure ulcers. So it's in good combination with those other practices such as hydration and repositioning. When we look at the ROHO Enhancer, this differs a bit in that it's a 2-manifold system versus 4. So the inner and outer cells can be adjusted as shown in the drawing on this slide. Varying levels of height supports positioning of the legs, improves lateral stability, and improves proper height supports in the positioning of this cushion. It also aids in the prevention of stage 4 wounds as well. And as you can see in the drawing there are varying levels of the cell height, which is going to help with abduction-adduction control as well. And then the last product we have here to talk about today is the ROHO Hybrid Elite Cushion, which offers stability by supporting abduction-adduction control, yet still offloads pressure from the IT and coccyx region via air cells. Dual compartment cushion sizes provide additional positioning for residents with asymmetrical postures. And if you look, it's got a combination of foam and air. So the foam in the front is going to help support that abduction-adduction control, whereas the air is really going to help float the pelvic region and offload that pressure from the IT coccyx region. All right, if you have any questions, please don't hesitate to reach out. There's my contact information.
Thanks, Kelly, and thanks again to Elizabeth. For more information about upcoming webinars or to view past webinar videos, please visit directsupply.com/webinars. Once again, thank you for attending today.